Hi, everybody. I'm Mark Raven from KaiNexus, and welcome to the webinar, Ask Docs Anything About COVID-19 again. We are joined again by Dr. Greg Jacobson and Dr. Mason Mileur, and with that, we're going to really just jump right into questions. We had questions submitted in advance. So first question is both sort of high level, and then it gets into detail. How likely will this be widespread across the United States? What's the best way to protect ourselves? And then when it comes to masks, there's no consensus yet about wearing a mask in public. What's your take on this?
I'm happy to jump in and then I'll pass it off to Mason. First of all, there is a pretty good size echo. Oh, the echo went away. So I think the cat's out of the bag on how extensive the virus is going to be in the US and obviously even the world. So I think there's zero chance this is not going to be a widespread illness. It's going to affect every large city, I think small city, and even a rural area in the United States. The biggest factor that we have that we all individually control our destiny is how severe the spike of cases are going to be and how concentrated are they going to be, and that we have been referring to as flattening the curve. And so that's all I'll say there, and Dr. Mileur can expand on that. From my side of things, there's really two major things that we can do to individually protect ourselves. One, decrease the number of interactions with other humans that you can have. So what I mean by that is direct interaction or even indirect interaction. So the mantra that we've all been now hearing is stay home, save lives. That's basically what that means. Only go out if something is absolutely essential. When we do go out, we need to not touch our face. We need to wash our hands frequently. The best way to not touch your face is to put something on your face so you're not touching it. It just so happens that when you do wear a non-medical mask, you're going to decrease the amount of virus that you can inhale, because some of that virus, if you were to be coughed on or sneezed on, or someone gets within 6 feet of you and starts talking to you, it's going to decrease the amount of virus, if they have it, that they are going to spew to you. And then I think the other important piece of information is, prior to you having symptoms of the infection, there appears to be about a 1 or 2 day period where you're spreading the virus. So you're also wearing a mask in case you're in that time frame that you're decreasing the amount of virus that you're putting out there in the world. And we can talk a little bit about proper mask wearing, donning and doffing of a mask in a second, but before we get too far off that, Mason, do you want to expand upon any of those concepts?
Yeah, I think the idea that if it's going to be widespread or not is like we were just talking about here, it's already spread. There's no stopping it at this point. As far as how to protect ourselves, you're right. I mean, it's just, I think we can lull ourselves a little bit into a false sense of security. Especially, I mean, right now, I don't think anybody's feeling very secure when they're looking at mortality rates, them cases going up now, people dying of this year. But as we get to a point at some point in the future where it starts to become a little bit less, I think that's where it's going to take a lot of us to decide, hey, how, when can we start relaxing? And we're going to get into that later. I know, Greg, that's called the dance at that point. But as far as the mask question, I delineate based on, are you at home? And if you're at home, you don't have to wear a mask. It's not going to really help anything. Or are you not at home? And if you're not at home, then you really should be wearing a mask if you are in a building, in an enclosed space of some kind. I don't see much of a help for masks if you're just taking a walk outside and you're maintaining your personal space like you should. But then again, it's not going to hurt. So I think at the end of the day, if you know you're going to walk outside and maybe stop inside of the neighborhood corner store to get a gallon of milk, well, then you probably need to be wearing your mask during that time.
There was, I think, a related, fairly detailed question I think you've already answered, but just to confirm, someone asked, is it safe to work from home on an outdoor patio and would be necessary to wear a mask?
Yeah, I mean, just to directly answer that, it is 100% safe to work at home on an outdoor patio and assuming your outdoor patio doesn't have anyone else on it, then there's no value whatsoever in wearing a mask.
So there's another question here asking, do we really need to assume that everyone has this? Is that true even if we're staying at home and having groceries delivered to us, or if I'm dropping food off at to my dad, I try to stay away from him and don't touch him? What are your thoughts in general and about scenarios like those?
I mean, I tell my patients, so what I'm telling my patients is just like what we said, I mean, the less you have to interact with anybody, the better. So think about your father. If your father is in his 60s and has COPD, you probably don't want to talk to him or even go in the house. If you can leave the groceries on the front step and wave through the window, that's the best way, because any little bit you can do to prevent that. All it takes is, all you have to do is at one time be able to transmit enough of that virus, then he has it, So I would say, now if your dad is staying in the house with you and you're having to live in the same house, honestly, at that point, you're all in the same environment anyway,
Yeah, I think you could if you were in a situation where you were living with someone that was high risk. And then that person, I think the more they would stay in their room, and then if they come out, they're wearing a mask. The more of those kinds of things that you can do, the better. This isn't, completely black and white. There's this huge area of gray that really you're just trying to decrease the number of interactions you could have where you could get the virus. So the way I think of things and the way I'm explaining things to people so they can kind of get into the infectious disease mindset or the keep things sterile mindset. I mean, we're not talking about sterility, but all the concepts of being in an operating room and understanding what's considered sterile and what's not considered sterile apply to this. So I think of it as things that are contaminated and things that are not contaminated. So to me, my house and me are areas that are not contaminated, and then the rest of the world is contaminated. So how is that applying to dropping off food from, if someone drops off food or delivers your groceries? I would consider whatever is being dropped off as contaminated. And so then I would just develop a process where if I touch that stuff, now my hands are contaminated, right? So then I want to wipe those things off and put them in a non-contaminated place. And then while I'm doing that, I would probably be wearing a mask because I don't want to accidentally, while I have contaminated hands, touch my face. And so then I would go piece by piece, decontaminating it. Then I would take the bag that it came in and throw that away, consider that contaminated. Consider everything that I just cleaned not contaminated. So then I would go wash my hands appropriately, and now my hands are decontaminated. So that same kind of process can be applied to a mask. So as soon as you put the mask on and then you go interact in the grocery store, your hands are now contaminated. Just consider them to have virus on them, and then realize that you probably are going to touch that mask at some point in the store without you even realizing that you're going to do it. So then when you're done with the store and you're walking out, you're cleaning your hands really well. You are taking the mask off with the back part of it, the loops, or however it's being attached to your head. I'm just putting the mask on the passenger floor because that's as far away as I can get it, and I just leave it there. And then I'm washing my hands. So anytime you touch the mask, wash your hands with some hand sanitizer. That's the way you go from kind of being contaminated to decontaminating. Now, when you're at home, all the bags and everything I would consider contaminated. So then I would have the process of getting those decontaminated and go from there. And so that's the approach I would take while we're in the hammer phase. As we're learning more from science and as we're learning more about this virus, those recommendations are certainly, I mean, I'd be surprised if that's 100% correct. It's either going to most likely be that we can relax some of these things, but it may end up being that we learn that we need to make those things even more stringent. So time will tell.
There's a couple of follow-up questions. I think it's a short answer to this one. Is it safe to go running outdoors without a mask as long as I maintain at least 6 feet away from everyone?
Definitely.
Do you feel comfortable giving a timeline, a number of days for when things should not be touched without being cleaned? Library books, for example. Packages might be another thing like that.
That goes back to, if you look at the lifespan of the virus on various surfaces. So library book, for instance, if it's a lot of library books have that protective, if it's from the public library, have that little plastic layer on the outside. It's perfect. And all you have to do is just take that library book and spray it down, like you would, or wipe it down or something. Be on the safe side. But to be honest with you, that's overkill, probably. When it comes to how long a virus is able to maintain its actual ability to infect you on even a plastic surface, you're talking 72 hours, if it's a paper surface, like, picked up a bag of tacos, which, probably shouldn't do, probably should make them at home, but let's say you did, then that they're saying that, on the bag itself is a matter of hours that it can do that. But you're touching that bag right after someone else touches it too. So I think you just got to, I think that's a really good way of looking at it, Greg, how you said it's like contaminated, not contaminated. Just treating it like, hey, it's probably, just assume it's contaminated and try to extricate out the food in the most non-contaminated way you can. But then again, that was prepared by somebody. So again, you're kind of stuck.
But a couple of people ask a different version of the same question. How fast, or do the germs, the virus at all, move across our bodies? Is there any migration? For example, if I scratch my forehead, is there any germ migration toward our nose, eyes, or mouth? In general, how migratory is the virus across our bodies?
I don't know of any evidence that says the virus has any ability to migrate. Are you familiar with anything, Mason? I mean, I don't think it has any.
It doesn't have the structure to do it. So you move it. That's how it works.
Right. So if you touch your forehead and you have virus on your forehead, then it's not going to infect you. The issue is that you're going to touch your forehead and then you're going to touch your mouth or your nose, and then as soon as you get into that moist mucous membrane area, then you're licking your lips or you inhale. So then that's how you're transporting it and getting it inside.
But if you scratch your forehead, it wouldn't fall and become airborne. It's so
I guess. I mean, it doesn't have legs, and it's not like, or like cilia or like little hair-like projections and moving its way around. I mean, viruses are literally, little pieces of RNA or DNA. So, the genetic material encapsulated by some protein. That's all they are. They're simpler than bacteria. Bacteria are pretty simple as an organism. Yes.
So I have a couple questions about being away from others or being quarantined. One question: if you stay at home for 14 days, visiting no stores, only going for walks alone, could you go visit a highly susceptible family member who needs help?
I mean, I would answer this: if you are 100% certain that you have had 0% chance of encountering the virus, then the best data we have right now is that 14 days is the outer limit that you can have the infection and not have the illness, if you will, the incubation period. So I would say yes. I would probably argue I have a hard time believing that you could really isolate completely for 14 days. So then I would balance that with how good have you isolated versus how important is it to see the person versus how susceptible is the person if they get the illness. What are your thoughts, Mason?
Yeah, I think it's just a risk-reward analysis that you're talking about. So, I mean, there are so many ways if you're just talking about, you miss them and you want to see them, that's really what FaceTime or Zoom or any of these other things are kind of here for. But if there is something some sort of service that you have to provide, for a parent maybe or something. But again, I think it really boils down to, yeah, sure, you're probably going to be okay if you're doing everything right, but you have no way of controlling every single variable in that situation, and who knows what they're doing. So I'd say the other question you have to ask yourself is, you might pick up something on their end that you're then transmitting around. So like from a population standpoint, the less you interact with another person, the better at the end of the day.
A related question, I've been in self-quarantine for 3 weeks since my daughter and I got back from Kentucky, where there were a couple of reported cases. Are we clear now? And I guess there's a question of what does that mean, being clear? If they, what are your thoughts?
I think you have to define what clear is. So if are we clear to go to the movie theater? No. You know, like there are certain behaviors that we've all said we're going to hold off on doing, you know, but if you mean by are we clear to practice walking around the neighborhood and maintaining 6 feet of distance between other people and stuff like that, then sure, I'd say so. 3 weeks is a good amount to.
I mean, am I clear in terms of have I likely not contracted it? But isn't that part of the challenge? Being asymptomatic doesn't mean you don't have it, right?
Right.
Yeah, well, I think that's how I interpreted the question. Are they clear from the chance that they have the infection? And the answer to that is if they've been 100% isolated, then yes, all the best science says that they will have a 0% chance of getting the infection. Keeping in mind that you're absolutely right, Mark, they may have had a completely asymptomatic manifestation of the illness. So, I mean, they might get their antibodies tested at some point, and they might be surprised to find out that they in fact did have the illness at one point. That's why this is a little bit of the perfect storm, unfortunately. I mean, viruses that are always extremely severe and always kill people very quickly are going, like, you know, Ebola. We've had a lot of Ebola outbreaks. None of them have spread widely. And so this is one of these illnesses. This is a virus that has a bunch of mild manifestations, but it also has this pretty significant portion of the population that have very severe manifestations of this illness. And so it's kind of, it's a perfect storm.
So another question, how many strains of coronavirus are circulating the globe during this pandemic?
I'll take that one, Greg. So right now we don't know that there may be multiple strains in terms of maybe some particular mutation setting it apart. But as it stands right now, there's not been anything to suggest that it changes its behavior or characteristics enough to change what we do about strain A versus strain B.
Yeah, I mean, the coronavirus is a whole family of viruses, and from what I've learned about coronaviruses in the last few weeks, because really in med school, you just learn that, oh yeah, there's these viruses called coronaviruses, they cause a common cold. Very little has really been done with understanding what they do. I echo again, I apologize. So there's essentially 4 strains of coronavirus that cause the common cold. And now there's SARS, which is, you know, the 5th strain that causes obviously a more severe illness. And then this is, the SARS-CoV-2 virus. My understanding is there are several hundred mutations to this virus, but they are not meaningful. They're not changing the way the virus looks or any of its little projections or anything. So that's actually really comforting news that so far with as many infections, the virologists, people that study viruses, don't think that it has mutated in a meaningful way. And by meaningful, that it's going to create a different kind of illness in a human. So that's, I think that's a great piece of news.
There was another part of the question I think it might be worth clarifying. When we hear coronavirus and COVID-19, COVID-19 is the disease that's caused by this coronavirus, correct?
Yeah.
If that's the vernacular.
Yeah.
Go ahead, Mason. Yeah.
I was going to say, the way I understand it is COVID-19 is the novel virus that's causing the illness. So it's the COVID-19 is the exact, remember saying the coronavirus is a huge family of different viruses, and COVID-19 is this particular virus that's causing all of this that we're seeing right now in terms of, the infections and the fatality rate. So I think there is a little bit of a distinction between like the name of the virus, meaning COVID-19, and there's a lot of different names out there for this, and we're not going to necessarily get into that. But for sake of argument, COVID-19 is what is causing then this kind of illness that goes everywhere from asymptomatic all the way to being placed on a ventilator.
Okay, thanks. There are a couple questions here along the lines of, is it possible to have reinfections, or do people become immune to this virus after they've been exposed to it?
I'm happy to tackle that. So the short answer is we don't know. We are very hopeful that it will act like many other viruses do, where when we get a virus or a bacteria or any other pathogen, anything that causes an infectious disease, our body's immune system will create something that looks a lot like a key or a kind of this binding thing to whatever it is. So we'll just say this virus, and when it binds to it, it kind of coats it, and it makes it either kills it or breaks it open or makes it inert where it's not interacting with our body. It takes our body about 7 to 14 days to make a new antibody or a new key, if you will. So we believe that you will have some immunity. Sometimes our body will make an antibody for its entire life, and then sometimes your body will make an antibody and it won't last as long. And that kind of is the easiest way to conceptualize why some things you will have some immunity for maybe a month or a year or a couple years, and sometimes you'll have an immunity for life and you'll never be able to get that disease again. So we don't know exactly how this coronavirus is going to act, but I think the best guess is that it will confer some immunity for some period of time. So theoretically, you shouldn't be able to get the illness kind of back to back. The other thing that's really kind of leaning us towards that thought process is that people that have had the illness were able to extract the antibody from. So the specific virus, and we're creating an antibody. So we're able to get that antibody from humans that have had the illness, and we're then able to inject that antibody into people that are currently having the illness. So you're going to learn a lot about convalescence of the disease and convalescent therapy. And the biggest news, I think one of the biggest news on the medical front is in the last week that medical journal JAMA put out a paper. Now it only has 5 patients, so we can't extrapolate a lot, but it's comforting that these 5 patients appear to do better once they got the convalescent serum from a person that had the illness. And so I think we're going to learn a lot more about that. It's just one of the examples of why the longer you can go personally and not get the infection, the better, because we are learning more and more and more about this disease. I'll give one other example. Listening to a bunch of really smart ER docs and intensive care doctors on the front lines in New York and in California, where they're seeing the most cases, they're just in this 2-week time frame are changing their approach to how they're setting the ventilator settings once you go on a ventilator. And they're already even changing the approach of when they believe you need to go on a ventilator. So that's just 2 weeks that they're already starting to learn about this illness in the United States. So you can imagine what the medical community is going to do in the next 2 months from the standpoint of really understanding. We talk about, you hear doctors like, oh, we give supportive care. Well, supportive care can mean a lot of different things, and there might be the best ways, and there might be not as good of ways to give that type of care. For example, ibuprofen would be supportive care, but there's some data out that says ibuprofen may not be the best medication for this illness. So there's just going to be more and more and more of that, and the longer we can go and not get the illness, the more we'll be able to fight the illness if and when we get it, with all the advancements that are going to happen.
Okay, wait, another question. We all see a lot of things on social media, but what's the best place to go if we want to go confirm what information is good or bad? It's hard to keep up. it's hard to determine who's really setting standards for best practices with all of this.
I'm happy to jump in there. I'm biased. We are putting a ton of information out on the KaiNexus blog. I'm writing a email every day to my network, which includes, several hundred, maybe 300 or 400 email addresses now. And we're putting those emails on the KaiNexus blog. We can certainly share. You want to share that? Is that easy to share? And so I am referencing articles that I think are meaningful. And 2 days ago, I think I did an email that just did a situational analysis of the last 2 weeks. So if you want to kind of go through all of what I think, there's probably about 20 pieces of information that I think are meaningful right now to make sure you understand. I have found that the New York Times is a great non-medical source, and I found that the Atlantic seems to be writing really good articles. And so you kind of immediately, when I start reading an article, I start realizing, oh, is this article have depth, or is this just kind of a surface article talking about things that may not matter in 24 hours? From a medical standpoint, and I'm sure internal medicine has similar things, but in emergency medicine, there's companies and put on by ER doctors that are totally geared toward medical education. So one of the ones I use is MRAP, and they are putting out weekly podcast, webinar-y type of situations where they get together and a couple infectious disease docs, a couple intensivists, a couple ER docs, a couple cardiologists. There's a lot of cardiac manifestations of this illness that we're starting to learn about now. And they're synthesizing all the literature coming out and kind of making it more consumable for the medical community. So those are probably kind of my approach. Mason, what's been your approach?
Pretty similar. I definitely approach with a lot of skepticism anything that's kind of in a news agency of any kind. Usually they have something they're trying to, an angle, if you will. So I like to go to places that don't have an opinion really as much about, they're just trying to give me data. And so that would be just like what you're talking about. I think the physician community has been doing a pretty good job of having these little forums on various social media platforms that actually has, been pretty good. And about people that are on the front lines talking about, wow, well, we adjusted this vent setting or, whatever. And that's been helpful for me to see. As far as if I were a non-physician looking for a reliable place to get this information, this good information would be, I actually really like the blog posts that you guys have been posting on KaiNexus. I think that that's been very helpful. And then if you just go to places like, the kind of the bigger entities, CDC, things like that, might be a little bit more dry, but I think that that's probably your most reliable place.
I did put a link in, and Greg also put it there. There's a couple different links. One is a general resources page. The first link there is a separate page we maintain with all sorts of different external resources. Then there's the blog post and there's Greg's emails there.
I think the only place or the only topic that I'm disappointed in the CDC, and I understand that they have a lot of stuff going on with this recommendation, but I think if you talk to physicians personally, we are all of the opinion that wearing a barrier on your face is only going to be a good thing to do. And so I know they have, I know the CDC hasn't formally come out recommending that, but if you go to those links, my last email, I think I've had now 2 or 3 emails on Friday, Monday, and then yesterday's email were all showing the data and the reasoning behind why we should all be wearing masks, because it will essentially make the hammer phase, the total lockdown phase of this, more effective. And the more effective we can be in the hammer phase, the quicker we can get to the less restriction phase or the dance phase, where we can start getting our lives back to a normal kind of cadence. So the longer we do the hammer phase, meaning the less well we do it as a population, the longer it's going to have to last. It's kind of like if you can study really, really hard for 1 hour, that's sometimes better than kind of studying for a test for 3 hours. You sometimes will do better just by really focusing. That's what I think we need to be getting to on the hammer phase of the country.
You've touched on some of this a little bit. Maybe if you can just go ahead and answer about the risks. Should we be concerned about contracting this at grocery stores? And then secondly, do I really have to decontaminate everything? If you can just kind of give a quick summary in response to that.
Jason?
Yeah, I think grocery stores are the probably most likely place you're going to get exposed. Everybody has to go there. You have a lot of different services. People are, picking something off the shelf, examining it, putting it back on the shelf. You hope they're doing less of that, but so yeah, I think that's if you are doing everything right, you're still having to go get groceries probably. And so I think that you really have to exercise caution there. I don't think anything is too ridiculous to do. I mean, wear a mask, gloves. They have been trying to figure out if gloves are really useful or not in a place like I don't think you can really tell. I wouldn't tell you not to, let's put it that way. And then as far as other things, wiping everything down, kind of depends on what the surface is. I think we talked on the last one about, Amazon packages. If you just kind of leave them out for a day, then you don't have to worry about wiping it down. But if you're, have a takeout bag from, plastic bag from HEB or something, yeah, you probably want to treat that like it's contaminated, and either dispose of it in a way that keeps you from touching it or wipe it down.
And two comments. One, from a glove standpoint, I agree. I don't think I would tell you not to wear a glove, but I'm certainly not going to tell you to wear gloves, because you can't get the virus from just touching a surface with a virus and leaving it on your hands. The only way you're going to get the virus in that case is by then touching your face. So if you're going to the grocery store and you're wearing a mask, I'm not advising you to wear gloves, because all you need to do is frequently wash your hands, and certainly wash it after you touch the last thing, and certainly wash them as you doff the mask or take off your mask. So I think that's kind of the thought process there. The other thing that we didn't mention with the food delivery is the virus is really sensitive to heat. So if you're ordering up hot food, you can be the person that's going to get contaminated, so to speak, and then maybe your partner or your wife, husband, whatever, can be the person that can literally just scoop out the hot food from the container and then just throw the container away and then wash your hands. That might just be the easiest way versus trying to wipe off these containers and whatnot. So just another thought. I would certainly be leaving out all of the non-perishable things. There is zero reason to bring those into your house unless you're starving to death. Just let those sit outside in your garage or out on the porch for a few days and let all the virus degrade. There's no reason to mess with that, in my opinion. So yeah, that's how we're dealing with mail. We're just taking it out and letting it sit for a day, and then kind of sorting through it, a day or two later. It seems to be the easiest thing to do. So
there's a question about, this might be hard to answer, depending on where the person is, but what are the requirements right now to get tested, and what do you recommend we tell our employers if we get sick but we can't get tested because the symptoms are mild, but they're still sick enough to not want to work?
I think it's going to be on a region by region area. Right now, my understanding is that we don't have a lot of testing in Travis County. We're in Austin, Texas. So I think trying to get testing is going to be difficult. And the testing that we are doing are for patients that are getting admitted to the hospital and for healthcare workers. Those are going to be populations that are going to need testing much quicker. My opinion, and I think that would be the medical opinion, would be that if you feel like you have a cold, then you should just figure you have COVID-19 illness, and you should not go into work. The approach, so that's if you're symptomatic. The approach is if you interacted with someone who is a known positive, ultimately becomes a known positive, then I think if you take all the known precautions that we're talking about when you go into work, which it would have to be an essential job, right? And hopefully the work, for example, I have a good friend, and he runs and basically like an internet sales company. And so what they've done is they've done a lot of measures in their warehouse, so their business does not have to close, and they're able to safely transact in business. They've rearranged the workstation so people are staying away from each other. They've gone into shifts, so there's half the number of people there. People are wearing masks. They're taking temperatures at the beginning of a shift when they walk in. So there's going to be safe ways to conduct business if your business is deemed essential. And I would hope by now that your employer would recognize that, hey, I'm telling you, I have a upper respiratory infection, whether it's mild or not mild. I think in the pandemic timeframe, you would just have to consider that to be COVID-19 illness.
I agree. Especially, I have an internal medicine office, and so we have to exercise a lot of extra precaution. And so we've been maintaining space inside the office, all of our employees, but then also do a test at least once a shift where we're checking temps and asking the questionnaire. But then anybody that is potentially exposed or has symptoms, we have a very strict policy: don't come in. And I think this is where the onus is a little bit on the employers to make it easier for their employees to stay home. I think where you're getting into a lot of problems, you kind of see it lately here with the Amazon thing we were talking about a little while ago, and some other places where people feel obligated to come into work because they need the money. And I think if you can remove that barrier as much as you can as an employer, the better off we're going to be. So I've told all my employees, like, listen, I'd rather pay you to work from home than, pay you to come here and give us all coronavirus.
Okay. Another question: is it true that a lot of warm, hot liquids would be a good safeguard? What about vitamins like C or D3?
From my opinion, I kind of get this all the time, and there's not been anything to definitively say that a certain vitamin helps you. I think in general, the healthier you are, in other words, get plenty of sleep, drink, things that make you relax so you can get that sleep that night. Exercise. Certainly, there's nothing wrong with any of the vitamins. We definitely haven't seen anything to say a certain vitamin makes you more likely to get, COVID-19. So for sure, I would go ahead and do it. But I think a lot of people that are looking to a certain supplement or vitamin as the answer, right now, there's just not anything to say that that's the case that we know of so far.
That would be the only thing that I think would be different that I would like to add is that, well, it's not different. It's just in addition to, from what Mason said, is on our resource page. I think one of the last links is a pretty well written article that goes through kind of all the natural homeopathic treatments and a little bit of the science behind any of those. I think, melatonin is one of those things that's been, I've read a little bit about. The way I would look at it is that those aren't causing harm and they might be beneficial. So I'm not going to recommend someone not take it, but as a medical professional, I'm not going to recommend someone to take it. I will definitely recommend, and my team has called me out on this week, that getting 8 hours of sleep a night is the best thing you can do for your health. And so I committed to everybody that I was going to get that last night, and I feel great that I did that. So the studies are completely unambiguous. I mean, there's tons and tons of literature that your immune system works way better when you get 8 hours of sleep. There's a great book that I've mentioned before, which is called Why We Sleep. I'm blanking on the author's name. I'll bet Mark can help me out here. But one of the entire chapters is devoted to the immune system and how well the immune system reacts to sleep. And if you don't get enough sleep, or you have, just get your 8 hours. If you want to know more, go read that book. Why We Sleep.
Matthew Walker.
Thank you, Matthew Walker. It was a fascinating read, or listen to.
There's a follow-up question here. What about steering wheels or other surfaces in your vehicle? How long would germs remain on the door handle, the push button to start it, the shifter, things like that?
Yeah, plan on it being 24 to 72 hours. So, I was that one video that Greg, I think you sent it to me. It was the link to how they're doing kind of practical mitigation issues in China, and they were just talking about how they're kind of treating it like a contamination versus not contaminated. So like in elevators, they had a box of tissue that the guy said, look, I just pull this tissue out and I push the button with it and things. So I mean, in your own car, if you're the only person driving it, then you probably don't need to worry about it. But if you're sharing a vehicle between multiple family members, then yeah, I mean, but again, though, if you're already back in the house with the family members too, I mean, I don't know how much you're really helping yourself in that situation, but the same concept applies to other surfaces that you might come into contact with. Maybe not your car, but door handles on businesses or other homes or things like that. For sure, you need to treat it, like you would as if it's contaminated.
I'll add to that. I don't know if this question originates from a company that I utilize here in Austin called New Wash, where they come to your house or your work and clean the car. And I spoke with the CEO of that company on, my thoughts of how could you safely run this company in the COVID era. For one, we're in a stay-at-home order, so I can't imagine keeping your car cleaned is considered an essential operation. But I'll leave that to the authorities and to that company. But from the standpoint of how could you do this medically safe, I think if the car was clean and then you let the car sit for 2-3 days, I think you're good. I think if the people that are cleaning the car are wearing a mask, are probably wearing gloves, and taking off those gloves, putting them on and then taking them off right away, that will help. Almost treating it like a medical procedure, if you will, that will certainly help as well. But if you're the only person in the car, it's an irrelevant point, because you either brought it in the car and you have it or not. I mean, the virus doesn't, it's not spontaneous coming out of thin air. It has to be placed there. So the easiest thing would be to only use a car that you're using or someone in your isolation group is using, if that makes sense.
So another question here, if you've got a patient at home who does need to be isolated on their own, and I've read about you've got to have your own bedroom and your own part of the house ideally, but what if you've only got one bathroom in the home? What would you do?
I think that's just a matter of cleaning. So I think I would probably try to think through. I mean, you're really using the bathroom for two main reasons, right? If you're evacuating, then hopefully you're not touching anything other than the handle on the toilet and toilet paper, and you're washing your hands afterwards. If you're using it for bathing, then you're going to touch a whole bunch of other things. But I think when you are coming into the bathroom and you know that the COVID positive person has been in there before you, I would treat that as if you're going into a grocery store. And I would treat that room as contaminated. Even if that person cleaned it, I would clean it back again. But the other option could simply be, I'm going to wear a mask when I go to the bathroom, and I'm going to, use a little toilet paper to flush the handle. And that might be a time when you decide not to wash your hands when you walk out. If you're not going to expose anybody, but then the only other remaining time would be when you wash your hands. Maybe that's a great time for hand sanitizer, just to wash your hands that way. So that's how I would approach kind of the bathroom with regard to when you need to go to the bathroom for a second versus when you need to do your daily bathing kind of ritual. I kind of split those apart. But if you're doing the daily bathing ritual, then you're going to have to wipe down every surface between people.
And also, if your sick family members in a room, you're going to manage that vent that's in the room a little bit too. Just think now, like for the air conditioning, if you can try to close it as much as possible, things like that. Because I don't know, Greg, if you've thought, I've tried to ask myself, and it's like, well, you know, in an apartment complex or other places like that where you're really stacked up, I think it's important to think about that, at least that aspect of it as well.
Yeah, I mean, like, that's interesting. I hadn't thought too much about that. I know that I've read and listened to the South Korean lectures where they say that they have cultured the virus from ventilation. But I mean, I was thinking if the vent is positive pressure, meaning it's bringing air into the room, that's different than a vent that is the return air.
Well,
yeah, so I would not put the sick person in a room that has the return air. That's like, that's a no-brainer. Now, I know in new houses, they have these, like their vents that connect rooms to like equalize the pressure. And so I live in a really old house, so we don't have those. And every time you open up one door, kind of the other doors shift, but on a new house, they have those. I would close those. I would 100% close that off.
Right.
If a person's sick, because yeah, theoretically it could make its way.
Yeah, a lot of the new, yeah, that's exactly right. Most rooms in a newer home have return vents in every room. And so.
Yeah, so if it's the vent that's taking air out of the room, that's the one to be concerned about.
Right, that's a good point.
So can you elaborate on what you meant by apartments, or I'm here in a condo building, 20 stories high, 100 units, and people stacked pretty close together. What was your concern about? I don't know how much air is shared across units in the building.
Well, I don't know if every unit, first of all, is going to be totally different. You know, I don't know how they clean their air and things like that. I mean, as long as there are systems, and I bet you they do it for liability purposes, especially the bigger places. You can actually have like various types of like UV light and things to help with that. But I guess where I was getting at my thought process, and this is more of a question out, like thinking out loud, is, you know, what kind of dynamic is there in New York City that's different than here? You know, just because there's a ton more density in terms of living. And I've always kind of wondered if maybe that has anything, if y'all heard any kind of studies that have been done on, have they been able to be able to detect any of the virus in ventilation in, you know, highly dense housing units, you know?
I don't know. I haven't read anything or seen any studies that say two apartments that are not connected, the virus is hopping from one to the other. So I think if I was in your place, Mark, the way I would think about it is my unit is the non-contaminated part, and then as soon as I walk out of the unit and I'm in a public space, now I'm in a contaminated part. So I wouldn't. If I was going on a walk and I was you, I would wear a mask as soon as I walked into the common area, went down the elevator, and then when I got outside, if you wanted to, you could take the mask off. Just keep in mind when you're taking that mask off, if you touch the front of it, you know, make sure to touch the side and like maybe hook it onto your clothing or something, because that's the most chance that you're going to get an infection as a medical care worker, assuming you have adequate safety equipment, is when you're taking off the safety equipment. So that's the same thing applies if you're wearing a mask. The chance that you're going to be contaminating yourself is when you take off the device or the equipment of some sort.
There was another question talking about workplaces in our office area. And this could be at a hospital, this could be someplace where people are still coming into work. There are air conditioning vents directly above. Can the virus be spread from the circulating air that blows out? So I think you've sort of touched on this, but anything else you would add about that workplace environment?
I mean, if someone coughed into the return vent directly, you know, and then it went and spread around, and yeah, but then again, you're diffusing that virus, that viral load through an entire ventilation system. So I think to me, when I'm thinking about it, that to me is the answer. Is it's a matter of not can I detect one single virus in a ventilation system. It's what's the load of virus, and does that meet the threshold to infect? And most of the time, I would say probably not, because the bigger the complex, the less likely that you're going to, first of all, have intake inside units. I don't know how they're designed. I'm not that kind of person, but maybe their intakes are not really in the units themselves. Maybe they're in the hallways or outside. I'm not sure. But then, yeah, even if someone managed to place a cough laden with virus right on the intake, it would still spread through the entire ventilation system. It doesn't divide on its own in that situation. It's not like your load goes up spontaneously. So it gets diffused over a large volume of air and space to where I don't even know if it would really do anything at that point. But
yeah, I that's not an area I would focus on. I just don't think people are getting this from more direct type of contact versus in the air. I mean, there's a lot right now on, is it aerosolized or is it in droplets? And the way I'm describing this is whether it's aerosolized or in droplets, to me, is an academic question. And what I mean by that is it's academic in that the size of the particle is what defines whether it's considered aerosolized or whether it's considered droplet. And so the virus is it's on some spectrum of like, this is a really, 1 to 2 micron, super tiny little, ball of water or mucus with some virus versus, this is several hundred microns big. And so I think the logical reason to be wearing a mask is because most of the virus that's coming out of your body that you need to be worrying about is on the bigger particles versus the smaller particles. So even if one of those tiny little particles that almost weighed nothing were to get sucked into a ventilation system, the viral burden, the amount of virus that your individual body would see would be tiny relative to someone sneezing on you or coughing on you, or the third thing there is talking. And I think everyone now realizes that when you talk, there are little bits of droplets coming out of your mouth. And we were talking about it yesterday on our stand-up meeting in the afternoon. But who hasn't been talking to someone and a little piece of spit that the person's talking to you, like spittle as they call it, kind of flies into your face, and then you're kind of like, oh my God, the person just spat on me, and you're like trying to figure out how you're going to wipe it off and whatnot. So that happens, and I think that's why the plexiglass barriers are going up at grocery stores. Why the recommendation for wearing masks is because it's a probability thing, and we're just trying to decrease the probability versus it being 100% or 0%.
I think that's the important concept to think about here is it's a matter of load. Remember, it's not just one single virus floats through the air, lands on your nose, and then now you have the virus. It's typically a load. It takes a certain amount, and I don't think any of us really know, but I mean, it's like I said, you have enough. Believe me, if someone coughs in your face, that's enough to get you sick. But
there's another question here, very, very general, but any precautions you need to take with
what? With what?
With pets.
Pets. Yeah, so we talked about that this morning in our stand-up. So this virus does not infect other organisms other than humans. So it's not like you can give COVID-19 to your dog, and then your dog, running through a COVID-19 illness, and then 7 days later can encounter another person and then give it to them. So the virus is not going to replicate on or inside of your pet. The way I think of it, though, is if you have COVID-19, you put that virus on your dog, like you pet the dog or you give the dog a kiss or you rub your face in the dog, then fairly soon after the dog goes and interacts with someone else, there is a theoretical, I think probably more than a theoretical chance that you could give someone else the illness, kind of using the dog as the object that's transferring the virus. So, but if you were to give your dog love and you had COVID-19 and then not interact with your dog for 3 days, and then that dog were to interact with someone else, then the chance that would spread the virus, I think, is approaching 0. I don't know if that answers your question. But I think this is not the time when you're out for a walk to be interacting with other people's dogs. And you shouldn't let them interact with your dog when you're out with a walk.
There's another question talking about walking. I feel like I could do some activities safely, playing golf, hanging out with friends 10 feet apart, etc. Should I do those things now?
So I think there's going to be a time when we can golf. I think if a golf course is preparing in the COVID era, then I think the answer is going to ultimately be yes. We actually have a blog post on it that hypothesizes a bunch of different things you could do that would decrease the amount of human interactions that we have. I think if you have a conscience at this point, and you look at the stories coming out of New York, and I mean, there's stories this morning literally where they have 500 people in a 200-person hospital that are patients there. They're putting patients in the lobbies. People are dying in the hallways. I mean, this is not a time when we need to worry about golfing, in my opinion. So I think during the dance, golf courses are going to reopen, and they're going to say, if you want to walk and not use a cart, or you're going to have one person on a cart, and we're going to take off the poles, and we're going to put the PVC pipe in there, and so it doesn't. I mean, there's a whole bunch of things that we could imagine that would allow you to golf with a lot less interaction from human to human contact. My personal opinion right now is this is not an appropriate time to be experimenting with those things.
But there was the one thought, or the thing here about hanging out with friends.
Hanging out with friends. So I'll talk about that. And Mason, I'd love to hear what your thoughts are about that. So we are going to experiment with that this weekend. We have a couple coming over. They are going to sit 10 feet apart in the driveway. And we are going to, there is no theoretical scientific reason that I could think of that if you don't get within 10 feet of somebody and you guys are just interacting, and y'all aren't sharing, so they're bringing their own chairs, you're not giving them drinks, you're literally not having anything that you've touched interact with that person, and you're not touching, and they sit, let's say 10 feet away to be extra safe, then I think that's a very appropriate thing to do. Someone sent me a video of kids trying to do this, and within 30 seconds of the video, the kid on one side of the street that's like 4 years old or 5 years old or something was on the other side of the street. So I just don't think you're going to be able to do this with small children. I think you're going to literally have more stress and aggravation with small children than you would by just simply trying to do something on Zoom. So I don't know what your thoughts are about that. I think also the other thing to think about is the people that are coming to visit us are not high risk, and you know, I mean, I guess I don't consider, I'm 45, so I don't, or about to be 45. So I'm certainly not 75 with medical conditions. So I think we're balancing the risk. But Mason, what are your thoughts about that?
I have 4 kids. My oldest is 6. My youngest is 1. There's no way I could control them to not run immediately over and slobber over every single person that we're trying not to expose. So, I mean, it's a no-brainer if you have kids. If you're adults and, you know, there's, you know, 2 adults and then 2 adults on the other side of the street of the driveway, I think that's reasonable if you're, you know, doing everything that Greg was talking about. I mean, there's just like kind of what he said, from what we know now about the virus, there's nothing to say that that's not allowed, or that I don't see how that could do anything at all at this point. But if you have kids, I just definitely would not recommend it. And hey, I mean, even if you have a dog, like you pet your dog or whatever, then it runs over and wants to be scratched by your friends across the street, that's just as bad.
Yeah, so our plan is, and we've already orchestrated this thought process with the friends coming over, and kind of we're going to keep our dogs inside. They're not bringing their dog, and so we're going to do this. Just what you have to keep in mind, it's kind of like soccer versus basketball, right? You just need one goal in soccer to win the entire game. You know, you just need one defensive breakdown. So you only need one time that you all of a sudden kind of screw up where you could potentially create that interaction that could spread virus. So this is, to me, if you were doing this with multiple couples, I mean, that's like, that just seems like a disaster waiting to happen. So this, to me, feels like if you're going to try to do something like this, this is with, one person and then one other person, or a couple and a couple, or something where it's like one isolation group and another isolation group. This isn't like, oh, we're going to have 4 isolation groups all come to a soccer field and, I mean, no, this is, I think during the hammer phase, if you're going to try to do this, no pets, no kids, you've got a plan, you're not sharing anything. The person can't come over and touch the mailbox. They can't touch your car when they're walking up. I mean, those are all things to consider while we're in this hammer phase.
Okay, so we're at the top of the hour. Maybe let's do 2 more questions. One's about testing, one's about treatment, and then a wrap-up question. Have either of you been following the testing of potential treatment drugs? There's different names being thrown around. How promising do these seem towards treating COVID-19, or how would we determine that as the general public? What are your
I'll take that one. Sources? So, well, I think the 2 big ones that everybody's heard about are Plaquenil, which is chloroquine or hydroxychloroquine, very similar to it, and then the other one is azithromycin, which is an antibiotic. So they're thinking that, first of all, I'll just say there's not a double-blind study with enough of a population to really take away anything. So everything that we've looked at has been what we call anecdotal, which means I had 5 patients that I treated with this, and all 5 patients got off the ventilator, or things like that. So you kind of have to take it with a grain of salt. But I mean, so far, I think that the chloroquine, hydroxychloroquine, we'll see. I mean, just kind of, that's my approach. Is you got to realize about that medication in particular, it's not like we were talking about with vitamin C, where it's like, hey, it's not going to hurt you, so what's the downside? With chloroquine, I mean, that's a pretty potent medication that they stopped using for malaria because it ended up, their better medications came out, that didn't have quite the side effect profile. So now they use it for like rheumatoid arthritis and stuff. I mean, so I would not go as cavalier with Plaquenil of, hey, if your doctor is saying, I think you might have the virus and you're 35, let's just go ahead and treat you with Plaquenil, that's not the right decision. This would be, you're really sick and we are really trying the best we can to keep you out of the hospital, or if you're in the hospital, we're trying to keep you off of the ventilator, then let's try this. What do we have to lose? I think that's kind of how you approach it with Plaquenil as it stands right now. The azithromycin component, there is an anti-inflammatory side of it that I think it might be helpful. And then there's also the side that it prevents pneumonia in an already compromised lung, which is what we call a super infection. So
a bacterial pneumonia, a secondary pneumonia.
Right. So anyway, I think that, that's kind of how I'm understanding those 2 medications right now. And then other, I don't know, Greg, if you have anything you want to say about other interventions.
Yeah, I'll make 2 points to add to what you said. One, I certainly don't think this is going to be a silver bullet. I think if this was a silver bullet and took mortality from whatever it is down to 0, and someone came in real sick and you just gave them 5 or 10 days of this medication and you could discharge them, we're not going to find that. We would already found that. So this is, maybe it improves your survival by 10 or 15 or 20%. To me, those things aren't going to change any of the way you should be interacting in the world during the hammer phase. And then the second thing is we already have a national shortage of those medications. So this is a situation where these medications are only going to be used in the sickest of the sick. And think about the logic of it. So if you have a really small chance of dying from something and you decrease that chance by 20%, doesn't really help you that much, right? But if you have a really high chance of dying for something, a doctor looking at you and you have an 80% mortality based on how sick you are, and you can decrease that person 20%, well, that's pretty meaningful. I mean, that's going to potentially help 1 in 5 really, really sick people. And so there's this concept of, number needed to treat to save a life and a whole bunch of other things. I think the bottom line is I would put that in my brain as the entire healthcare community is thinking nonstop on how to improve the outcomes from this illness. These are a couple of things that they're trying, and these are appropriate for people that are being admitted to the hospital. And we have a national shortage of those medications. So if you have those medications, I would probably hold on to them. And if your local hospital says, hey, we're out of these medications, we want to collect them from the community, then that's when I would give them. I would definitely not take them if I started to have mild disease and wasn't under the care of a doctor or wasn't doing that in combination with the physician. I think what's interesting and perhaps going to ultimately be more promising, but this is just my blink on it, is the information coming out about convalescent serum. So we talked about antibodies before. So when you have the infection and you successfully recover from the infection, we now know that you will make antibodies, these kind of those little key attachment things that can neutralize the virus. And so what they've done is they've taken it out of people that have successfully recovered. They've taken out all the stuff from the blood that they don't need, and they basically just have those antibodies. And then they inject those antibodies into a person that has the illness. And they just did the publishing of 5 patients that appear to do better. So again, Mason talked about, randomized, double-blinded, placebo trials. That is the gold standard of the absolute best type of study that you can have that proves something is of benefit or not. And so this would be considered an observational study, which is the lowest quality kind of study that doctors use. And so there is, just in my 20-year career, there is just so many examples of things that we thought were really good and we started doing, and then they did a really good, high powerful, good quality study, and it showed that it had either no effect or in some cases it actually was even worse. So
best case of that is that aspirin study they just did that everybody thought, if I take an aspirin a day, it'll keep us from having a heart attack. And they finally did a study on it, and it turned out it not only didn't do it, it actually increased your risk of bleeding in your brain. So
great example. So that's how I would process all that information. And then I think the biggest information I had this week was when I watched the MRAP, those ER doctor generated, and the intensivists and ER doctors were saying that this illness is unlike any pneumonia type illness they've seen before. There is lots of things they're learning. They're changing their approach on when people put people on ventilators and when they don't put people on ventilators. They're figuring out exactly. So we are going to learn a ton in the next couple months, and the longer we can let the medical community learn, I think the better off we are. We are crafty little organisms, and we will figure this out. We just need some time.
Okay, the other question we have here, you'd mentioned antibodies. What do you know about testing for the testing that would detect antibodies and that being available to the public? Other countries are starting to test to see who has already had it to enable some returning to work. This is maybe when time about going from the hammer to the dance, letting people go back to work is part of that dance phase, right?
Well, I'd say that right now we don't really know what to do with that. So I'm going to create a scenario. So let's say that we're in the dance and you go get a test because you think you might have been sick 6 weeks ago. Turns out you have antibodies, okay? Now, there are all different kinds of antibodies that this test could be looking at, the little keys that Greg was talking about. You have some that are more permanent, and that's called IgG. You have other ones that are right in the moment when you're infected or right after, it's IgM. And so, first of all, the first question you have to ask yourself is, what kind of antibodies are we deciding are valuable to have? Probably IgG, and then the second thing would be, what's the significance of having those antibodies? Do they actually prevent you from getting the infection or not? And so when you are going through all that, you have to really decide, if it turns out there's a level, a threshold that you have to get to in order to have immunity, then that's called a quantitative analysis of that. And so we don't know if there's a certain level you have to get to in order to reach immunity, or is it just a qualitative, you have it or you don't, you know? And so all that to say is, right now there are tests, and in fact I'm participating in a study out of California looking at that very thing, and that's great, but it's really meant, I think the way I see these tests are more of data collection and interpreting that data rather than an absolute, I have antibodies so I'm good so I can go back to work.
It's going to help us figure out what to do as a population more, I think, than an individual, at least in the short term. Is that what I'm hearing you say?
Yeah.
Okay, so we've covered a lot of really, I think, useful tips and information for us in our everyday lives. And thank you for doing that. Maybe as the last question here that came in, kind of bring it back to some of the bigger picture again. Does it appear like this challenge will end anytime soon?
I mean, soon is a very relative term. So, obviously, that's the $64,000 question. You know, no one knows how long we're going to be in what phase. So I'll take a stab at this. I've been telling folks and talking to folks that, to me, the hammer phase is going to be measured in weeks, and the dance phase is going to be measured in months. And when I say measured in weeks, I don't think this is a 1 to 2 week scenario. I think weeks might be, 4, 8, 12. It's going to be something in those terms. And then I think that restrictions are going to lift, and we're going to be doing those things in the scale of months. So it might be that we need 8 weeks to get a hold of our curve, or it might be that we need 12 weeks. Let's just pick 8 weeks just for conversational purposes. And so we're at the end of May, and the curve isn't going up anymore straight up. The curve has started to look like Italy's curve. I'm picking such a long time because of the lack of the hammer, just how tight the hammer has gone down. Has been a little more lenient than any other country out there. I mean, even Italy, once they started to lock down, it feels like all the stuff I'm reading, and we have one of our customers is based in Italy, and the type of stuff he's talking about, their lockdown is more severe than our lockdown. I don't know what the lockdown looks like in New York other than what I'm reading. So if it's 8 weeks of lockdown, then I think you're going to start getting this staged roll out of restrictions being lifted. And I think each stage of that will last a month or maybe 2 months. But I think that those will be focused on getting the economy going back again. So if that's soon to you, then the answer is yes, that's soon. If that feels like a really long time for you, then that's going to be a really long time. I think we need to get into a mindset that, and it's sometimes hard to understand, we are in a historic time. There's literally only 2 other pandemics that are in this classification. The Spanish flu in 1918, and then the plague back in I think it went from the 1400s to the 1700s, somewhere in that range. And so we're not talking, this isn't a MERS or a SARS or an H1N1. Those were all probably classified as pandemics. I don't know, there were blips on my historical memory, but we just crossed 1 million people in the world, 50,000 deaths. And I mean, unfortunately, we're still at the beginning of this. So I was talking with my wife last night. I mean, this is the prior most significant thing that's happened to humanity before this, in my opinion, is World War II. I mean, that's the level of the scale that we're talking about. World War II was, at minimum of a 6-year event, however you want to classify it. So I don't think this is going to be a 6-year event for us. I think that we will be forever changed by it. But I think that this hammer phase, like I said, is going to be measured in weeks, not a low number, but a higher number. And then the dance is going to be measured in months. And probably the most realistic things that I've heard of is there's going to be some kind of dance between 6 to 18 months, something in that range. And we're going to be I guarantee you that people that are a lot smarter than me are going to be reevaluating that on a day-by-day basis.
And that's at that point we're hoping that a vaccination is available to basically, and then it changes dynamic to penetration of that vaccination into a population, response of a population to that vaccination, and mutation of the virus to overcome that vaccination.
All right, well, thank you. And I did put a link in the chat box if you want to grab it before we close down the webinar, that article, The Hammer and the Dance, if you want a deeper dive into that terminology that's been used here today. So I want to thank everyone who attended and thank everyone who submitted questions, whether you attended live or submitted them in advance and you're watching a recording. I want to thank our panelists here, Dr. Greg Jacobson, Dr. Mason Mileur. Is there anything else that you want to add before we wrap up?
I'll just end with the statement based on the observation that how we interpret this event, in my mind, has to do with perspective. And there is zero question in my mind that there's going to be a ton of suffering and death. And there's really not much we can do about that. I mean, that's viruses are part of the human condition. I think we could focus on that, and we will not be better off as humans if that's all we're focusing on. The amount of inspiration and hope and us coming together is going to be unparalleled that we're going to see. I saw a video on YouTube recently where someone had gone through the streets of Austin and just showed the lack of people on the streets. And the statement was, I mean, it looks like the end of the world. And then the interpretation that they concluded with is, no, this is not the end of the world. This is a sign of solidarity, human solidarity, to do the thing that we can do right now, which we've talked about during the last hour. And to me, the amount of hope that fills me with, and the amount of inspiration that filled me with, hopefully we will be better off as humans from this, from an emotional standpoint, and how much we care about each other, and how we can just maybe not be so divisive. So that's how I'm choosing to interpret the events. Mark.
I was muted. Sorry, Mason. Is there any final?
I feel the same way. I think that my doctor hat is all about how do we minimize and mitigate and all that kind of stuff. My human hat is saying that we really can make it through all of this. We just have to keep our heads.
Well, thank you. Thank you for that. Thank you for everything you've shared. This was actually the second of these webinars that we've done, so you can find the recording of the first one from, was that 2 weeks ago already?
Feels like an eternity.
Yeah, that recording is still out there on YouTube and our podcast channel, and things are changing quickly, so I'm guessing another one of these might be in the future. But please keep an eye on our webinars webpage, KaiNexus.com/webinars, or if you subscribe to our YouTube channel or to our podcast, you'll be notified about new recordings as they come out. So again, on behalf of the entire team at KaiNexus, on behalf of our panelists, Mason Mileur and Greg Jacobson, I'm Mark Raven from KaiNexus. Thanks for being here today.